Welcome to the deep dive. Today we're really getting into something fundamental, a skill that every single professional clinician must master. We're talking about the effective and, more importantly, the safe supervision of junior staff.
Hmm. It's absolutely critical.
We've taken all the sources, the official GMC guidance, the exam prep materials, and we're going to try and distill it all. The mission here is to create a really clear, actionable framework for safe oversight, especially for when you're under pressure.
And that pressure is exactly where these skills are tested, isn't it?
Yeah.
Let's set the scene. Imagine this. You're the senior clinician on call. A new junior doctor has just started, someone you've never worked with before, and they're telling you they're not familiar with the local hospital pathways.
Okay, a common scenario.
And then, bam, two urgent referrals land at the same time. One is a patient who is clearly crashing with sepsis. The other is an urgent head injury with a worrying mechanism. Your junior is struggling, calling you repeatedly for help. The question isn't just about the medicine.
It's about managing the risk.
Exactly.
Yeah.
The risk of the situation, the clinical urgency, and, the junior's inexperience all at once.
That just throws the core truth of this topic into such sharp focus. So let's unpack this. Supervision isn't passive, is it? It's not just signing off notes at the end of a shift.
Not at all. It's an active, proportionate process.
Okay, so if we accept that, what's the one-liner, the single most important thing for our listeners to take away from this?
Right. It all boils down to this. You have to match your supervision to the clinical risk and the junior's competence.
Yeah.
You set explicit briefs, clear review times, you stay available, you step in early if you need to, and you document everything. That's the whole safety covenant in a nutshell.
I like that phrase, proportionate. And this isn't just for doctors in training, right? This applies to physician associates, AHPs.
Everyone. It's about ensuring all staff can deliver safe care while also, and this is key, being supported to learn effectively. If you look at the GMC's Good Medical Practice for 2024, paragraph 15 really hammers this home. It says the supervisor's duty is to ensure appropriate supervision and, crucially, to act immediately to keep patients safe if they have any concerns.
That's the exam mindset we always talk about. High scores come from showing structured oversight, not just, good intention.
You're spot on. It all rests on that relationship between two things, the risk of the task
Right.
and the junior's competence to handle it. You just scale your supervision up or down based on those two variables. It's that simple.
So you'd never leave a new doctor to manage a crashing patient with, say, a really low blood pressure or a low GCS on their own?
Absolutely not. And defining those numbers, the SBP, the GCS, that's part of the instruction you give.
Okay, let's get into the framework you've pulled out. This seems really practical, moving us from just reacting to, making structured, safe decisions. Can you walk us through the first couple of steps?
Of course. It's a 5-step process that takes you from the very first thought to the final documentation. So, step 1. First, you assess. Assess the risk of the task and the competence of your junior. This is all about preventing what we call unsafe autonomy.
So finding out, do they actually have the experience? Have they been signed off for this?
Precisely. You need to know that before you do anything else.
And once you've done that assessment, what's next?
Step 2 is to define the supervision level. Based on what you just found out, is it direct supervision, where you're right there in the room? Is it indirect, where you're nearby and available?
Or is it just a review later on for a low-risk task?
Exactly. You're setting the boundaries right at the start.
That clarity is so important. Step 3 then moves into communication, setting those expectations.
Yes. Step 3, brief them clearly. And this isn't just the task, it's the time frame and, most importantly, the red flags.
Here, red flags.
You're creating a shared understanding. What to do, how long to take, and when they absolutely must stop and call you.
I think defining those triggers is probably the most important part of the whole instruction.
It is. Because if you don't define the trigger, you can't be surprised when it gets missed.
True.
And that leads into the last 2 steps. Step 4 is to review the outcome with feedback. You have to close the loop, check the work. Did it get done safely? This is your safety net.
And finally,
Step 5. The last thing you do is record it. Who owns the task? What decisions were made? What are the next steps? It's the cornerstone of accountability.
that is an incredibly systematic approach. And to help remember it under pressure, the source material has a mnemonic, right? Guide.
Yes, a guide is a great mental checklist. Gauge the risk. Understand their competence. Instruct clearly with red flags. Direct the level of oversight. And enter it in the record. Follow guide, and you're covering your GMC duties every single time.
Let's switch gears and talk about the traps, the decoy detectors, as the sources call them. Those answers that sound okay but fail on safety. What's the
Yeah.
biggest one?
Oh, the most common trap by far is unsafe autonomy. It's the answer that says something like, let them manage alone. It's good experience.
Right, the sink or swim approach.
Exactly. And while the intention might seem good, it totally ignores the risk assessment and your duty of oversight. Patient safety always, always comes first.
So what about something a bit more subtle? Like if I say, just keep an eye on them, it sounds supportive, but why is that a low-scoring option?
Because it's completely vague. It's useless from a safety perspective.
Hmm.
Keep an eye on what? For how long? What are you looking for? It has no structure, no triggers, no deadlines. It fails steps 2 and 3 of the framework.
And the other big one seems to be delaying help, saying something like, call me only if it's serious.
That's what we call inaccessible supervision. You're basically telling the junior to wait for a disaster to happen before they escalate.
You want them to call before it gets serious.
Yes. You set lower preventative thresholds.
Mm.
Tell them to call if they feel any uncertainty, not just if the patient arrests.
This all brings us back to those high-scoring model phrases. They're all about specificity, aren't they? Giving actual numbers.
They are. So instead of that vague, call me if there's a problem, a great phrase would be something like, okay, talk me through your plan. Now, if their pain goes above a 7 out of 10, or their systolic blood pressure drops below 90, or if you feel any uncertainty at all, you call me immediately. I'm on bleep 1234.
That's so powerful. You've given them clinical markers, a contact method, and you've even made their own feeling of uncertainty an official trigger to escalate?
You're making the invisible criteria visible and actionable. That's the difference between safe delegation and, well, just hoping for the best. And that clarity is never more important than when you hit a red flag, a point where you have to stop supervising and just intervene.
Like a high-risk procedure being done for the first time.
Exactly. Or a patient who is actively deteriorating. Sepsis, a sudden drop in GCS. That is not a teaching moment. You step in, you make the situation safe, and you can debrief and teach afterwards.
Okay, so what if a junior is struggling with something more routine? Something they probably should be able to do. There's a pressure to let them figure it out.
The professional duty is always to step in to make it safe. First, stabilize the situation. Then you can clarify expectations, increase your supervision, give them some targeted support, and document what happened. If it keeps happening, you escalate through the proper channels, but you never, ever leave a colleague or a patient to fail.
Let's talk about delegation and ownership, because this is a big one. If I delegate a task, am I still responsible for the outcome?
Yes, absolutely, 100% yes. Delegation does not remove your professional responsibility for that patient's care. You are still accountable.
So you have a duty to verify the outcome.
You do. You have to review the work, make sure it's done correctly, and keep a clear record of that.
This must also apply to things like taking consent for a procedure, right? Can a junior doctor do that?
They can, but only if they are competent to do so. And that's the key. Valid consent isn't just a signature on a form, it's a whole process. The person consenting has to be able to explain all the material risks, the benefits, the alternatives.
And answer difficult questions from the patient.
Exactly. If the junior isn't experienced enough to do that properly, then a more senior clinician has to step in. It's that simple. You're delegating the conversation, not just the paperwork.
It just reinforces how vital that fifth step is, documenting ownership and decisions. It's not just bureaucracy, it's the actual safety mechanism. Okay, let's circle all the way back to that opening scenario. New locum, septic patient, head injury. We have to rank our actions. Using this framework, what's the top scoring, safest thing to do?
You have to prioritize the highest risk, most time-critical patient, the one that needs senior expertise right now.
Which is the sepsis case.
It's the sepsis case. So the best action is you personally take the septic patient immediately. Then you give the locum a very structured brief for the head injury. We tell them the pathway. You set clear red flags like checking GCS every half hour, call if there's any vomiting, and you set a really short review target.
I'll be back to review with you in 15 minutes.
Exactly. You confirm your bleep number, and you document those roles. Done.
And that nails the guide framework perfectly. You gauged the risk, understood the locum's competence, instructed clearly, directed oversight, and would then enter it in the record.
And you can see why the other options fail. Telling the locum to stop calling you is just a dangerous abdication of your duty.
Right.
Delaying both cases until a later handover is also unsafe.
And the subtle trap is misallocating the risk. Taking the more interesting head injury case yourself, and leaving the crashing patient to the junior.
which completely fails that core test of matching seniority to the highest clinical threat.
This has been a fantastic deep dive. Let's just quickly cement those core principles for everyone listening. First, always match supervision intensity to the risk of the task and the competence of the clinician. Second, set clear briefs and explicit red flags. Make the triggers for help totally unambiguous.
Yep.
Third, stay available and always verify the outcomes. Close that loop.
Crucial.
And fourth, document everything. Ownership, decisions, learning points. It protects everyone.
And remember, all the terms we've used, GMC, good medical practice, delegation, duty of candor, they're all connected. Getting supervision right is the thread that runs through all of them.
So I'll leave you with a final thought to mull over. We've established that safe delegation requires documentation and review. If those steps are routinely skipped, maybe because supervisors are too busy, what is the long-term impact on a team's morale, on professional safety, and ultimately on a patient's trust in the entire system?
Getting supervision right is the strongest defense for you, your colleagues, and your patients. It's a skill that's absolutely worth mastering.